So next session is Industry Symposia Novartis. The topic is Do the Early Bird Catches the Worm? Holistic picture of newer OADs, CV, safety and beyond panel discussion by Dr. Subramaniam Kannan, Dr. Arthur Asirvadam. I would like to invite the panelists, Dr. S. Muruga Pandiyan, Dr. Sriram Mahadevan, and Dr. Hari Janaki Raman.
Good evening, and thank you very much for the organizing team and the pharma company Novartis sponsoring this talk. Thank you for staying back. It's the fag end of the day. Wonderful sessions from the endocrinology of sleep, endocrinology of gender, thyroid nodules, and then tuberculosis, snake bite, and then finally we come back to our usual bread and butter of endocrinology, diabetes and diabetes management. When the topic was given to me, do early bird gets the worm, I asked Shaktivel, enna topic idu enakku unna puriyala idu correct explain pannunga. Then he mentioned that it's about the early intensification of therapy. How do you intensify therapy very early in the disease, and what benefits do you get, and how well you can manage diabetes, and what are the benefits of managing diabetes intensively in the beginning stages. And so that's the whole idea of the next 20 slides. I'm going to be very quick, crisp, actually show you some data from my own practice as well as some data that we have accrued over a period of years, and showing why you should be aggressive in your initial diagnosis of diabetes and management. We know that diabetes is becoming a pandemic. We are second to China right now, and it is projected that India will become the diabetes capital of the world pretty soon in 2045. We all know that this is a progressive disorder, starting off from a pre-diabetic to diabetes and complications. And if you actually carefully look back, a stage before the pre-diabetes is actually your NAFLD, or your non-alcoholic fatty liver disease. Whenever you start having fat hepatic steatosis, that's probably your starting stage where you're starting to develop the hepatic insulin resistance, start having higher triglycerides, lower HDL, then go on to develop pre-diabetes, and then diabetes and its complications. So this trajectory of this arrow that you see on the screen may have various slope, and that's what Dr. Muralidhar actually very nicely put together the paper that was published in Lancet about the clustering of diabetes. The slope may be very fast in somebody who's insulinopenic, who's autoimmune diabetes, and the slope may be very low in somebody who's only got an obesity-related diabetes or a very mild form of dysglycemia. We have also known that legacy effect and metabolic memory exists in diabetes. The early intensive therapy people in all clinical trials, both the type 2 and the type 1 in the UKPDS and the DCCT edict follow-up, showed that the folks who had intensive therapy in the early on phase of the diabetes ended up having much better, much lower rates of complications, particularly retinopathy and nephropathy, when they were followed up. And even during the follow-up, when the intensification was relaxed. So even if you had poor control later on, what mattered really was the early intensive therapy, and that's very important to know. Again, we also know that in people who had bad control, particularly in trials like the VADT trial, where you had bad control before entering the study, after you try to intensify them, you probably have no effect in terms of their complications. So the first 5 to 10 years after diagnosis of diabetes becomes the critical time when you can actually change how they're going to evolve into complications and develop complications later to diabetes. So I think it's an important, and they don't come to the endocrinologist when they're diagnosed with diabetes. They actually go to the primary care physicians and the family doctors, the general practitioners. So it is important for you that you intensify the therapy in the beginning stages. It is always being underplayed. I think patients underplayed, sometimes even doctors underplayed. Sir, so mild, konja borderline sir, utrala sir, paravala unna agadu, maathakam venam, no 6 months paathukalam sir. Do not underplay the severity. The chance that we have, the easiest time we have of managing diabetes is probably in the early stage of diabetes. Once they become complicated, they have complications, they're on insulin, things are very complicated even for the endocrinologist. So the starting stage is the easiest stage to treat, and is the time when you should actually get them to good control. So sugar normal, HbA1c 6.5, sir. Please do not do that. If you de-intensify your therapy, patients will go back to their usual lifestyle. Things will just go back to square one. Time and again, it has been shown again that, when you have early intervention, intensive rate therapy, you will have reduction in cardiovascular events. 2 trials showed this. Again, the 3 trials which countered some of these things was the VADT, ACCORD, and ADVANCE, where intensive therapy was not associated with fruitful outcomes. But again, the counter to that is that these people all had long-standing, poorly controlled diabetes. So when you try to intensify control later on in the disease, you may cause more harm. ACCORD clearly showed that if you try to push somebody with very tight control later on in their diabetes career, you're going to have increased cardiovascular risk, hypoglycemia risk, and increased risk of mortality. So if you want to intensify therapy, if you want to get them to 6.5, it's the best chance is when they are in the early stage of the disease, not in the later stage of the disease. The other important therapeutic strategy that we all follow, and one of the what we call as the failure to, when you treat to failure, you start with diet lifestyle, you start with monotherapy, it fails, you start up titrating monotherapy, you start dual therapy, you start triple therapy, you start insulin and then put on. So this is a treatment to failure approach, and sometimes this creates a lot of time lag before you actually give them the right treatment, and in the end, this because of a clinical inertia, physician inertia, patient inertia to change, we lose a lot of years in bad glycemic control. So by the time patient is actually on the correct treatment, you already lost 5 to 8 years of poor HbA1c control. So again, the stepwise strategy again will delay patients in achieving goals and increase the rate of complications. So our strategy should not just to be following the algorithm, what the various guidelines come up with, but to use our common sense at the same time. Use the principle that you have to hit this disease hard at the earliest stage. Again, one of the medications that is used in the management of diabetes is DPP-4 inhibitors. Again, DPP-4 inhibitors have multiple roles, although a lot of in vitro data and animal data supported a number of mechanisms by which these DPP-4 inhibitors could possibly act. When it came to clinical effects, we probably have not seen that much of a success with these drugs in terms of their in vitro and other effects that they was purported to have. Again, there is definite synergy between vildagliptin and metformin. I'm sure a lot of practitioners here might have combined, given combinations of DPP-4 inhibitors and metformin. You see that when you give the dual drug combination together, you're going to have a significantly higher rate of side effects, and that's clearly because the synergy between vildagliptin and metformin causing a higher level of GLP-1 levels, and that again, metformin also can increase your GLP-1 levels. By giving a combination drug, you're going to have a significant higher synergy, and that is why the side effect proportion also will be higher. So whenever you're getting a combination of these two drugs, you have to go slow and slowly up titrate the dose rather than giving them a full dose. But when you do that, when the patients can tolerate these drugs, you definitely do get a significant effect on the blood glucose levels. Again, depending on single pill, multiple pills, compliance always is much better with a single pill combination. Again, there have been studies which highlight usage of a single combination therapy to start treating drug-naive patients with type 2 diabetes. When you have type 2 diabetes, you start treatment with just metformin, you wait for metformin to fail, then you add the second line drug. Instead of that, there are studies coming up talking about initial combination therapy. In fact, the AACE is a little bit more aggressive than the ADA guidelines when they ask for dual drug therapy. When they say the HbA1c levels are more than 8, you want to have a dual drug to start with rather than a single drug to start with. So again, the treatment with dual drugs always will have some amount of benefit in terms of a longer run, because you're able to use this dual drug strategy or synergy much better in these patients. How long will the effect last is a difficult question, and I probably don't have answers at this point of time. Again, this clearly showing the effects. When you start off with a higher HbA1c value, you're going to have a much greater reduction of HbA1c with dual drug therapy. The higher you start with, the more drop of HbA1c you will get with DPP-4 inhibitors. Again, short duration studies, small number of peoples, you start seeing that there is a significant dip in dual drug therapy compared to monotherapy. Combinations of vildagliptin and metformin showed significantly more HbA1c reductions than monotherapies. Again, clear, understandable because of the synergistic effect of both vildagliptin and metformin. Again, vision study showing, very short duration study, only 24-week study, again showing you that there is a nice reduction of HbA1c compared to the monotherapy to dual therapy. And percentage of people who achieve HbA1c less than 6.5 is much higher with the dual therapy than with the single therapy. I'll just share some of the slides that I had with our patients, who present with very high blood sugar values. One of the things that we often see is patients who present with very, very high HbA1c values and very high glycemic levels. So these are about 73 patients, who are about 52 of them are males, newly diagnosed diabetes. These are all not previously treated diabetes, newly diagnosed diabetes, and then the mean fasting sugar was around 278, 2 hour post meal was around 393, the mean HbA1c was 11.7. Almost all these patients were all started on insulin therapy right in the beginning. So this is a time when you have to give them that insulin rescue therapy. So we put them on insulin, and then after about 15 days or probably about a month, we put them back on oral drugs. At the end of 1 month, when they finish their insulin therapy, their fasting dropped to around 118, their postprandial dropped to around 166. And then after a month, they were all put on various drugs. The biggest chunk we put them on was metformin and DPP-4 inhibitors, and you could see that they had a beautiful drop in the HbA1c, and at the end of 12 months, so what we did in the first month of intensive insulin therapy and then putting them on a dual therapy, kept their HbA1c well controlled, less than almost the HbA1c levels did not cross above 7, were well maintained between 6 to 6.5 for about close to a year's follow-up. And then at the end of 1 year, we had about 48 patients in whom the mean HbA1c was on 6.76. And the end of 24 months, this is 2 years, although the number of people who followed up become lesser, the mean HbA1c was 6.8. The point I'm trying to drive is that if you hit them hard early on, if they come with very high sugar values early on in their diabetes, it is worthwhile to treat them with intensive insulin therapy for about 15 or 20 days, or maybe about a month, and then put them on a dual drug therapy, preferably metformin DPP-4, or you could use metformin thiazolidinediones or metformin sulfonylurea, depending on what you think is ideal for the patient, and then you will be able to achieve good, durable diabetes control for about close to 2 years, is what we showed. And some of the interesting data that we got from our private practice model, where we have seen close to around 25,000 patients, is that DPP-4 inhibitor patients generally tended to have much better diabetes control compared to those who did not use DPP-4 inhibitors. Similar data did not exist for the SGLT2 as of our data. I'll probably share these slides more detail when we have more data. And we are really waiting for the most important study here, the Verify study, which is trying to look at the long-term clinical benefits, or addressing what we call as the durability effect of the vildagliptin over a long period of time in type 2 diabetes. So we are looking forward for this Verify study and to see if this early intensification has a meaningful effect on complications, on beta cell function durability, and to see if it's got clinical benefits to patients other than just lowering the HbA1c value. So intensive treatment may also have a risk factor modification, will reduce CV events in type 2 diabetes. Clinical inertia, as I said, will lead to delay in glycemic control, affects the quality of health care. The natural progression of diabetes and associated complications can be prevented or delayed by early initiation and intensification. The initial study showed effectiveness of vildagliptin metformin as a good combination drug for patients with dry eye in type 2 diabetes. So we wait for more data on the verified study. We wait for more data on cardiovascular safety data as well. And thank you very much at this point. Thank you.
Thank you so much, sir, for the enlightening speech.